Okay, good afternoon, everybody, and you're very welcome to the first afternoon session of the parallel uh, part of the conference. Um, I'm Kim Tully. I'm your Engaging Dementia host for this session. I'm currently the interim CEO of Engaging Dementia while Sinead takes a break to get her master's degree. So you're all very welcome today, and I'm very much looking forward to the presentations we're about to hear. This session is called Improving Dementia Care Pathways. During the talk, I would encourage you to enter any questions that you might have in the chat function or in the question and answer section. We will answer questions as we go along or at the end of the session. Also, we'll be recording this session. It will be available to you in the near future. And also you can watch other sessions that you might have missed from the two-day conference. So first of all, I'd like to introduce Dr. John Hudson from the University of Lincoln, and he's going to give us a talk on the cognitive daisy. Over to you.
Hello, everyone. My name is John Hudson. I'm a senior lecturer at the University of Lincoln in psychology. So I'd like to thank you for letting me talk to you about the cognitive daisy this afternoon. The cognitive daisy is essentially a tool that I developed with Petra Pollux. We've been working on this. It's really a tool to guide the decisions of carers and people with a wide range of cognitive disorders. So it's not only for dementia, any neurological condition where people have any form of cognitive impairment, the cognitive daisy might be quite useful. You'll be aware that in terms of dementia, there's a wide range of variation in the cognitive problems that different patients experience. Patients with Alzheimer's disease or multi-infarct dementia, Lewy body dementia, frontotemporal dementia, all different types of dementia that have different impacts on the brain. So in terms of the encroachment, also the stage of dementia, the progression, and there's structural variation in all our brains as well. And there's the notion of functional reserve. So collectively, these kind of different dementias impacting differently on individuals in different areas of the brain mean that there's a great deal of cognitive variation between one individual with dementia and the other, and I'm sure you'll be well aware of that. But that poses a particular challenge for people involved in care, because seldom will they be aware of the precise nature of an individual's cognitive status. So a patient with communication problems, in terms of language production, there may be alternative ways in which communication can proceed, maybe through gesturing or writing. But to people often involved in their care, that information is never readily available. Someone with a spatial awareness problem, again, if you approach them from their neglected side, you might make them jump, startle them. And again, if you was aware of that as a carer, any healthcare worker, then you could adjust your interaction. And the cognitive daisy is essentially a method for making those, if you like, cognitive strengths and difficulties that any patient has really visible to people involved in their care. So essentially, it's a visual depiction really of abilities and problems. And the abilities and problems are depicted in the form of a flower head, okay? Each petal on the flower head corresponds to a specific ability, and the status of that ability is determined by a cognitive test. If that petal's coloured in that particular area, that's indicative of there may be some difficulty with that particular ability. So if this petal here is coloured, it would indicate a problem with spatial awareness. If that petal's white, it means they have capacity for that particular ability. So it's presenting a unique kind of profile of capacity and difficulties in these different abilities. They're also clustered. So we have 15 petals, but 3 petals correspond to each of 5 broad cognitive domains. So we have the blue petals correspond to visual spatial skills, the yellow ones in terms of comprehension, the purple ones in terms of communication, the green ones for memory, and the red ones for attention. Okay, and so it's a bit about looking about capacity in these areas and presenting a profile for each person. So these are unique daisies that we've taken from people with different forms of dementia, and you can readily see that they're all from a residential care home, and you can see the unique variation, and it highlights the individual differences between one person and the next. So we can see this one here, Muriel. It's got no deficits in visual spatial processing, no language comprehension, no communication, but it's quite severe memory problems and also moderate problems in attention. Okay, we can see Bob in the centre has got quite pervasive difficulties in many areas of cognitive ability, but he does have this one white petal here, which maps onto his ability to understand language. And this was particularly prominent, Daisy, for people involved in the care of this individual, because he would often not interact in the care home and not engage with anybody. And so the care staff would often talk about Bob if he wasn't there. But when they found out that he could understand language, it kind of changed their interaction at an instant. Okay, so these very subtle differences, you know, can have a huge difference, we believe, in the care provider and the residents and different people with dementia receive. The grey petals you've noticed here on some of the daisies, they correspond to areas that we don't know the status of these particular areas, because for some reason the person didn't complete that particular test. So they may have been tired, it may have been across mealtime, so we don't really know the status of that. So if we don't know the status, then it's coloured grey. But you can see instantly these emphasise the individual differences of different people, all with a diagnosis of dementia. And we was interested in basically, so we came up with this idea about presenting cognitive abilities in this way, because our background's really in neuropsychology, primarily kind of experimental neuropsychology, but we've always had an interest in being able to translate what we know theoretically about neuropsychology into more kind of practical purposes. And so we developed this idea, and so we developed an abilities assessment, and we trialled it on people, older adults who are living in the community, just to get an indication of whether they'd be performing kind of at optimal levels on our different tests. And so we looked at the 15 abilities, as you've seen in the previous daisy, and we collected some normative data of 43 people who are living in the community. They were all able to complete the assessment. The assessment only takes about 15 minutes, 20 minutes to complete. And the only other measure that we gave, the standardised measure, was the 6 cognitive impairment tests. And they all scored within the normal range on that, so they didn't have any kind of deficits. So this is our kind of, if you like, our normative kind of data, which we're comparing any deficits to. Our first study really was about seeing as a concept whether it would actually be very useful. We wanted to know whether, you know, does it have any kind of utility? Because we was primarily trialling this in care homes, and we wanted to know if staff would buy into it. Is it practical? Is it beneficial? You know, does it improve knowledge of carers? So we ran an initial study in 6 care homes in the Lincolnshire area, and it involved 29 care staff and older adults. I can't remember the exact number because the screen's covered. But a mean age of 87 and a range from 74 to 96, all in residential care. And in terms of our outcome measures, we wanted to know, we developed 2 questionnaires. We call the Cognitive Daisy 1 and 2. And basically these were constructed to examine the carers' understanding of cognition in dementia, and also the understanding of cognition in the residents that they actually cared for. And we also conducted some structured interviews in focus groups at the end of the trial. And the protocol involved us training care staff, the workshop, learning to read and interpret those daisies. And so they all attended a 1.5 hour training session. And the assessments of the residents at that time was conducted by trained Admiral Ness, who we guided to be able to do the assessments, how to score the assessments, and actually create and produce individual daisies. And then for a 2-week period, we examined whether the cognitive daisy was useful in any way in terms of their intervention, how care staff actually used the daisy to guide their interaction with residents. So when we asked previously about what cognitive problems are associated with dementia, you can see in terms of memory, they were quite familiar with memory problems in dementia, and also quite knowledgeable that communication was an issue in dementia. But not many people would, mention visual spatial problems. Not many people mentioned actually comprehension, and not many at all in terms of attentional processes. Following the training, we saw a huge increase in the percentage who identified these specific areas of cognition being impaired in dementia. In terms of its usefulness, we asked whether how easy they found it to actually remember the cognitive profiles of the residents they cared for. And the grey bars are their kind of pre-intervention ratings off a scale of 1 to 10. And you can see, I think there's a mean score of 4.4 or 4.3 prior to the introduction of CogD. But then when we asked them on completion of CogD, how useful was it to kind of help you remember the cognitive profiles of the residents you look after, it increased to 8.4 in terms of a mean of 8.4 on the rating scale. So clearly they did, even those that found it not too difficult to remember the cognitive problems of the residents, it certainly improved in most cases. I suppose the most telling, and I'm not really familiar with qualitative analysis, but we've got a range of other kind of responses people have endorsements of the cognitive daisy if you want to have a look at our website. But they did find it a really excellent visual prompt to remind of each person's strengths and weaknesses. They thought it took person-centeredness, so the care of person-centered care, to a different level. And it really helped them understand the individual. It also encouraged them to think differently about the residents that they cared for. So that the actual changes how carers think about residents. They some of the more difficult behaviours in care homes. They tried to look for more cognitive reasons for more challenging behaviours. And they actually approach residents with awareness of their difficulties. It wasn't only, and this is an important point, it's not only the difficulties that the people with dementia were clearly had, that was important in guiding care decisions. It was also the white petals, which were the strengths. Okay, and they actually found the daisies useful for the care plan. So we didn't really think about it being used in the care plan, but they spontaneously used the daisies. And they used them spontaneously to discuss the residents in meetings. It became kind of, if you like, a language that they used in the care home. And it gave them a greater sense of competence in their care-related decisions. So that was the proof of concept. The second study, we wanted to see if it was viable in a whole care home. It kind of, the proof of concept stage, only a few senior carers in each care home participated. But if this is going to be rolled out on a wider basis, it's important that all care staff and indeed all residents were actually assessed. So we wanted to try it in a care home where everybody was involved. And we also was well aware that it had to run independent from us, the researchers, in doing the training. So we introduced a number of measures. One of them was an online training session, which staff can easily complete within 20-30 minutes to be able to read daisies and show how they can be used to guide their behaviour. And the assessment, we actually trained senior carers to do the assessments. And we took some more objective measures as well. So we looked at measures of competence, person-centred care, and also agitation. The results showed a 92% completion rate. So 92% of the residents completed the cognitive daisy assessment. We found, in terms of competence, it really improved the competence of care staff. And quite interestingly, which we looked at agitation in the carers, and quite interesting, we found a relationship between some of the petals on the daisy and some of the behavioural difficulties, particularly in terms of aggression that some of the residents displayed. So we know from this stage that they're finding it very useful, and you know, they certainly buy into the concept of the cognitive daisy. But the third thing we was interested in doing is finding out if they did anything differently. You know, do they actually use the daisy to guide their decision making? So this final stage looked at the efficacy in 41 care home staff. And these were carers, in this particular study, they gave judgments of how they'd provide care for different 5-case scenarios, okay? So that was a baseline in terms of their interaction, how they'd interact with these different scenarios. And then they did the cognitive daisy, and then with the daisy, did it change their interaction? And what we found that when the daisy was given alongside the scenario, it improved their kind of strategies that they'd use. So they'd use more gestures and writing for residents who had communication problems. It also made them much more aware of everyday kind of perceptual and attentional problems, and that became very much a part of their vocabulary and terminology in their interactions. In terms of the benefits, it's certainly it's cost effective intervention. We've developed an app that's kind of freely available to use. The training's really doesn't take that long, 30 minutes for carers to learn how to read the daisies, and something like an hour and a half for staff to learn how to conduct the assessment. It does kind of highlight strengths and difficulties, and kind of takes this individual kind of care to a different level, and encourage people to look at their cognitive difficulties and strengths. We can use it to monitor progression, because we really look at, one of the key things is it's not a scaled measure. It doesn't tell us how good people are in different abilities. So it doesn't tell us how good they are at writing, how good they are at recognising faces or objects. It just tells us if they've got the capacity for that, okay? And because it's about looking at capacity, we can do these assessments at different time periods. So I'd like to make some acknowledgements. It's been contributed to by a wide number of people in different aspects of dementia. I don't know if I've got time, but we are doing some additional work. Since we've done this pilot work, if you like, one of the key things what carers have said is like, how can we change our interaction? What can we do when we see the daisies? Well, we've developed a petal by petal guide. That's on our website that you can see. And basically, petal by petal guide, if somebody's got particular petal coloured, what kind of difficulties they might experience on a daily basis, what are the kind of things that you can do. We've piloted this in the community in a small sample with the Alzheimer Society, and they found it really very useful in terms of going into people's homes, explaining a very an overwhelming condition into kind of manageable kind of terms. It also, surprisingly, helps people with early in the stage of a diagnosis of dementia understand their own kind of difficulties they might experience, and also their strengths. So they found it very empowering in a sense, because actually kind of took a sense of ownership over their own daisy. It's currently being used by NHS staff in Derbyshire, who, as part of the cognitive reablement programme, to teach dementia care healthcare workers about cognition in dementia, and also to use the daisy in the community, and also some wards that they have in Derbyshire as well. So thanks very much. I'm happy to take any questions when you're ready.
Thanks so much, John. So what we'll ask people to do is put their questions in the chat or the question and answers, and then we can get to those later. So next I'm going to introduce Karen Gorman. She's a dementia support nurse at St. Joseph's Hospital, and she's going to tell us about the role of the dementia support nurse.
Hello, thank you so much for letting me speak with you all here today. So I'm the dementia support nurse in the day hospital in St. Joseph's, which is under the management of Beaumont Hospital. And my presentation is about the development of the role of the dementia support nurse, and really looks at how the role has continued to adapt over the 6 months with the impact of COVID. So there are many definitions which give us a glimpse or an idea of the impact of receiving a diagnosis of dementia. Lee in 2014 captures the anxiety of both the person receiving a diagnosis and their family when he said, "When people are diagnosed with dementia, they are faced with uncertainties of what will become of them, of what they will lose." This slide is just a small example of how overwhelmed a person can feel, and often how suddenly unsure they have of their future. So when I first meet people, we chat about what, of their feelings and their uncertainty. And these are just some of the things people have said to me. For example, "I still don't believe it. I don't want to be a burden to my family," or even, "I don't remember being told." So it's important to remember that they have been coping for possibly years with symptoms and then have participated in an assessment process before attending for dementia support. So it's vital to always begin by listening to each person, and throughout the focus will always be to put attention on minding ourselves. The dementia support is very much person-centred and meeting them at the stage that they themselves are at. The aim is to always make the most of the person's strength, their personal qualities and values, and encouraging them to kind of take it easy on themselves. So what is dementia support? The National Dementia Strategy in 2014 said that following a diagnosis, a person with dementia will need considerable emotional and practical support. Local, well-coordinated support services are needed to assist people and their family to cope with the choices and dilemmas confronting them at this often distressing and challenging time. So each person has emotional, psychological, education support and service needs, as well as signposting to local services. So I provide support through conversations, goal setting, tailored strategies with an emphasis on maintaining relationships, both within the family and also the community. So who are they? What matters to them, and what do they enjoy? So then I work with the person and their family, supporting and facilitating them through information, signposting, and contact within the community. And this can really allow re-engagement with services and activities. So this might have been suggested during their assessment, perhaps due to feelings of being shocked or overwhelmed. They may now need just the help of strategies and support to help implement this. So the length of support that I provide is very flexible, and the emphasis is really about maintaining a relationship with the person and with their family, and then hopefully then with myself. If further support is needed, I'm available to both the person themselves who has been diagnosed with dementia or separately with their family. But really it's important to maintain that relationship and that connection with community services. So development of the service. This post was originally established and supported by the National Dementia Office and Beaumont Hospital in 2019. As part of the post-diagnostic grant scheme, it provided 19.5 hours, which is a 3-day week, and within the last year and a half, it has become an integral part of the dementia pathway. And we're delighted to now say that there's been a further 2 years funding, which brings us up to the end of 2022. So that's great news. So the service is located in the day hospital, and all referrals are received from the consultant geriatricians. So a person can be identified from a member of the MDT, but they must be under the remit of the consultant geriatricians. So as a dementia support nurse in the day hospital, which links our community and our acute services, I play a role to help with linking the two, and this means in terms of communication, but also to help to identify if there's a person that needs that extra little bit of support or is struggling. So within the day hospital, I'm part of the broader multidisciplinary team. So that would be our OT, our nursing, our medical social worker. But also there is the FIT team within the emergency department. So if a person is identified as needing a little bit of support, they can be referred in as well. For a person with dementia and their family, it can be challenging, and it's important to acknowledge that one of my roles is to help a person and their family with complex issues or progression of symptoms. Therefore, being able to provide additional assessment and support as required to try and keep a person well and at home is so important and is appreciated. So to know that we're able to keep going for another couple of years is really, really important. So as a dementia support nurse in March 2020, it became notable within the first couple of weeks of restrictions due to COVID-19 that things were proving challenging in the community for people with dementia and their family. The restrictions closed community services and limited social contacts. In those first few weeks, I could see a noted increase in anxiety and then anecdotally progression in symptoms from reduced mobility to an increase in symptoms of paranoia, apathy, reduced cognition and increase in terror stress. So as the slide says, a report from the Alzheimer's Society of Ireland showed that people with a diagnosis of dementia are feeling lonely, trapped, and families are struggling with a decline in cognition. So unfortunately, figures from Alzheimer's Europe and the Alzheimer's Society of Ireland were to show that this was a true trend across the whole nation. A report in Italy found that there was a 70% increase in cognitive decline symptoms in people with dementia. And here in Ireland, the Alzheimer's Society of Ireland did a survey looking at what aspects of dementia had the COVID-19 affected the most. 86% of people reported that their daily lives of people with and carers with dementia was affected. And 40% found that it was impacting receiving a diagnosis or medical follow-up. And that was just two examples. So as part of my role, it would always have been to provide a teleclinic or phone clinic. And this proved to be really important because I was able to very much scale this up. So during this time as a dementia support nurse, until face-to-face service was back allowed again in June, I continued to provide this phone support. So in terms of support, I provided to those following a diagnosis or those awaiting a diagnosis. For those who needed strategies at home, it was a case of helping people to kind of cope with the day-to-day stuff, linking them into online services if that was appropriate, or posting out leaflets. Links to services. So some of the online services that were available were amazing, but not suitable for everybody. So there's an example up there of some of the phone services that were available. Staying in touch with our local community services, they were fabulous, from the guards to local GAA clubs. Managing crises. So that was actually probably one of my biggest roles during this time. So urgent reassessments to consultants, helping families to recognise concerns, education on delirium. A lot of people complained of isolation, so ensuring they had follow-up, maintaining relationships, letting people know that I'm here and what our services are open to them, that they're not alone and that help is available. So delivering of the service. So it's just important to say that it is very much patient-centred, and that although it appears to go in order, that it really does work around the person and their family, and that for sometimes for a person it's one or two is what I will focus on or what they will focus on, and that's how it goes. So I feel the most important part is providing a calm, safe, quiet environment. I will have received a letter of referral, which helps guide me. And then it's about ensuring that it's person-centred and going at their pace, recognising what they have lost and giving back some control. So with regard to support, it's about listening, about hearing their story, about giving them back their sense of control. In terms of disease progression, this is done with the person who's received the dementia diagnosis, but also with their family. So their fears are quite different. For the person, it's very important that they want to know how they're doing. But for the family, they often want to know what the future has to bring. In terms of routine, the emphasis on what's important in their life. And we talk about it being okay to get a little bit of help. It's also about establishing habits and routines. And we recognise that family do worry, and getting them to recognise that about each other can be important too. We talk about technology, which can be from the basic to the more complex end, and linking into services if that's what's needed. So for social connections, there's hobbies and activities. So we are positive and we are creative. The person may not always be able to recognise the change in themselves, and that's okay. We acknowledge and we talk about it, but we think about what is important. And we ask them to think about small things that they enjoy. There's brilliant booklets and leaflets out there that really help with that. In terms of COVID-19, it's often about the most basic things and breaking things down to in the simplest forms and finding what you really enjoy. And then routine is really important, so making things part of our everyday life. In terms of planning for the future, it can be about looking at supports. It can be doing with the enduring power of attorney, and that conversation can be a very practical one, or it can be a very emotional one. For carer support, again, at times that can mean just providing information on support services, but in other cases, it can be about providing carer support and education. So the year 2020 as a dementia support nurse feels a little bit like it's in two parts. So despite the COVID-19 virus, people continue to receive a diagnosis of dementia, and the role of a dementia support nurse continues. So it provided teleclinic and face-to-face clinic following all guidelines. So I've adapted the clinic since June, and in general, I only see a person with a family member for 2 sessions, and then follow them up as needed. So what this has done is that it's allowed me to meet a person within a few weeks of their diagnosis, but it has also then allowed me to try and catch up on those who would have been diagnosed either prior to the June period or else who have been struggling with complex needs. So the circle in the middle shows the people who were seen January to March. The teleclinics is from March to June, and then from June to October is the figures that we're receiving at the moment. It has been so important to remain in contact with my public health nurse colleagues, the day centre managers, etc. So although community services and clubs are closed, they continue to visit, to phone, and to provide activities for their clients. And by us all staying connected and in touch, we are able then to help to provide information, support, and keep connected with people in the community who may be struggling, and that keeps the lines of communication open. So I hope that helps prevent some of that disconnection that can sometimes go on. So the role of a dementia support nurse is in a day hospital is very multi-faceted. And I hope this gives some idea over the last couple of months how I've tried to help a person to kind of cope, navigate a little bit better with their diagnosis along with their families. So this slide just tries to capture just some of the concerns or the issues or the services that I would have addressed for the person over the 6 months. So it can be anything from dealing with a complex issue that might have required an urgent consultant referral to perhaps a medication management issue that we might have worked through introducing a routine, blister packs, to coping with social isolation and introducing online services and links into Alone. So anything across the spectrum. So in terms of seeing how we were doing, this very much has been a noted increase in referrals, and particularly over the last few months there has been absolutely no DNAs, which in itself reflects the need for the service. But in order to see what people themselves need and want and feel of the service, I posted out surveys to both the people who have received a diagnosis of dementia and also to their family. So some of the questions were yes and no's, looking at the information that they got, but I also wanted to ask them what, was there anything that they wanted else or wanted to tell me? And what came back quite strikingly was that across the board, what most people sent back to me was how important it was to be listened to and to express their feelings and to have a little bit of control back. So if anything is an advocate for dementia support, I think that to me is my absolute thing that I must remember when I'm providing dementia support, is that it's not always about the information and everything else if I'm not actually paying attention to the person and their family. And so that was always had to be at the forefront of my my planning. Thank you so much for listening to today, and thank you very much for everybody that's helped keep this roll going. Thank you.
Thanks very much, Karen. That was very interesting. A question came in for you. Do you accept referrals from the old age psychiatrists covering Beaumont? They often diagnose dementia.
No, but if they are already under any of the consultants, geriatricians, then yes. So once they're within the geriatricians in Beaumont, then they can come to the day hospital. So it's outpatients, it's the geriatricians in day hospital that way, but they must be under that remit. At the moment, because it's a developing service, that was what was the plan at the time. But it's very much growing.
Very good. Looks like it's developing as you go along, and especially with COVID too.
Yes.
Very good. Well, thank you. That was very interesting.
Thank you.
So any other questions for Karen, just put them into the question and answer or the chat. So now I'm going to introduce you to Claire. So this is Claire Rooney. Hi, Claire. So Claire is a clinical specialist occupational therapist at Our Lady's Hospice and Care Services.
Hi everyone, my name is Claire Rooney, as Kim just welcomed me there. Thank you very much for having me speak today. So I'm going to talk to you about the cognitive stimulation therapy program that we developed last year for people with dementia as part of a post-diagnostic support service in Our Lady's Hospice in Harold's Cross. I work really closely with Dr. Roisin Purcell, who is our geriatrician over in the hospice. And we worked really hard together, I suppose, to establish this service and to get it up and running last year. So what I'm going to cover today is, so I'm going to give you an overview of CST and the evidence and guidance that exists around it, the post-diagnostic service itself that we developed, the audit findings that came from the service, and then our plans moving forward and kind of how we've had to change the service in light of COVID. So I just wanted to start really by talking a bit around cognitive stimulation therapy and what that actually means. particularly for those of you who may not be familiar with it. So cognitive stimulation therapy, it's a brief treatment for people with mild to moderate dementia. So the sessions are designed really to actively stimulate and engage the person with dementia. So working on cognitive skills like memory, concentration, attention, problem solving, and then social skills in a group format. So the sessions are quite structured, and each session has implicit orientation, a discussion on current affairs, and then there's a general theme, which is a choice of an activity each week. And I think what's really important is that this is person-centered and that it's based on the needs of the group and also the wants of the group as well. So it's important to have that kind of conversation and an understanding of the people who are in the group itself. And the group sizes with CST, they do tend to vary. Within our groups, we have probably about 7 or 8 people in a group at any one time. So a bigger group, I suppose. Now we did have 2 facilitators, so there was myself as the occupational therapist, and we also had a healthcare assistant. And I think it's really important with CST that people are trained and experienced working with people with dementia. I suppose as an occupational therapist, we would have a lot of training around kind of group facilitation and activity analysis and person-centered care. And I think that that fits really nicely with cognitive stimulation therapy. The program that's most popular and most evidence-based is the Making a Difference program. So that was developed by Amy Spector and her colleagues over in the University College of London. So I'll just talk a little bit about that evidence and guidance, and most of the evidence that's out there does focus on the Making a Difference program. So in terms of what CST has been shown to do, it can improve memory and quality of life for people with dementia. And I think that's so significant to the person. It can also help to improve communication and social interaction. And I just know from my own experience, CST, it's a very strengths-based approach. It focuses on opinions rather than facts. So it gives people a really safe environment to practice and use their cognitive and social skills within a group setting, and it's a very comfortable environment for them. So as a therapy, I think it's a really nice approach for people with dementia. In terms of the guidelines and guidance, then when we're looking at the UK, so the last NICE guidance there in 2018 suggested that group CST should be offered to people with mild to moderate dementia. This is also reinforced in the UK by the MSNAC guidance, so the Memory Services Accreditation program over in the UK. So they have standards for memory clinics and memory services. So of the memory clinics in the UK, a recent survey suggested that 85% of those clinics are actually offering cognitive stimulation therapy to people with dementia. In Ireland, this is reinforced by the National Dementia Strategy, and I think what's been really encouraging over the past few days in the conference is to see the amazing and inspiring work that's happening around the country in terms of post-diagnostic support. I think we've definitely come a long way, but we still have another way to go in terms of delivering CST. I think it should be a standard for people with dementia, and it should be offered across the board for anyone who has been given a diagnosis. So now just to talk about the service that we established in Our Lady's Hospice. So this was the first post-diagnostic support service that we had in Our Lady's Hospice. And we started it last year in March of 2019 as a pilot project. And working with Dr. Purcell ourselves from the occupational therapy team, we adapted the cognitive stimulation therapy Making a Difference evidence-based group program, as I mentioned earlier on. So in that true format, CST is offered twice a week, so an hour session twice weekly over 7 weeks. What we look to do is offer longer sessions over a shorter period of time. And the reason why we did that was this was, I suppose, a pilot. We didn't have extra funding. So it was, I suppose, based on capacity, but also based on the fact that people were coming in for sessions and often relying on kind of carers for support with transport. and it was felt that maybe a longer session that they could get more time in the service would be of benefit to them. So we modified that program, and what we offered was a pre and post assessment, and we also offered 8 sessions of CST. We used outcome measures as standard practice as well in the service on a pre and post assessment, and I'll talk you through them just a little bit later. But first of all, what I'd like to talk a little bit about is just the inclusion criteria. So we offered the service really to anyone in our catchment area who was under a geriatrician that had a diagnosis of dementia, and that they were falling within the more middle or moderate stages of dementia. Now, the reason why we chose that was working with our colleagues over in St. James's Hospital. We wanted to develop a pathway for people with dementia. So the occupational therapy team over there offer a cognitive rehab program called the SMART program for people more in the earlier or mild stages of dementia. So instead of replicating a service that was already there, we wanted to I suppose, have a pathway and fill those gaps. So that's why we focused on the moderate or middle stages of dementia. Now, I have there that there was an MSE below 20, but that was really because it was a new service to give referrers as a guide and just a ballpark. But really the pre-assessment was really important to gauge where the person was at and whether or not they were suitable for the program and whether it would meet their needs at that time. Now, if it didn't, we could always refer them on to something that was more suitable for them. We also asked that a carer could attend with the person to the pre and post assessments, and that the person involved in the group could hear and see reasonably well to allow for group participation. The referrals we accepted, so they came from Dr. Bristol in our own service, and then the geriatricians over in St. James's Hospital and Tally University Hospital. So just briefly to mention the outcome measures that we used in the service. So we looked at cognition, quality of life, and then the experience of the person and the carer. So in terms of cognition, we looked at the memory questionnaire, which is a self-report memory questionnaire on the person's daily functioning in terms of their memory. So that's rated by the person and by the carer. The MSC most people will be familiar with. We use the quality of life Alzheimer's disease, which again is rated by the person and the carer. And in terms of getting, I suppose, the voice of the person with dementia heard, we felt it was really important to have a qualitative feedback form. So we developed one for the person with dementia and one for their carer. And again, that gave people an opportunity to give us feedback on the service and also to share their opinions in a confidential way as well. In that feedback form, just to mention, we did ask carers to give feedback based on how they felt their loved one got on in the groups and how they felt their experience was. So this was just a snapshot of the program that we offered. So as I mentioned, it was 10 weeks. On week 1, we did the pre-assessment to determine suitability and also give more information about the program itself, describe what CST is, and to help people feel at ease and to ask any questions that they may have. We had the group sessions then from week 2 to 9, so 8 sessions in total. And then on the final week, at week 10, we did a post-assessment. During the post-assessment, it was really important, I suppose, for us to discuss what happened next after the CST. That was something that came up quite a lot for participants, that they wanted the CST to continue. And it was really, I suppose, signposting them to community services like day centres, dementia cafes, men's groups, all those ones that we've already talked about throughout the conference within our local communities and how important they are. Our groups tended to happen on a Friday, and as I mentioned, the time was a bit longer, so we did from 10:30 to 12:30. And what was a really invaluable part of the CST program was that we offered people tea and coffee and refreshments when they first arrived, really to support that kind of natural social interaction and to give people an opportunity to settle into the group and to meet other participants and to kind of build those relationships as well. The carers were offered a 4-week support group with the medical social worker, which again was a really beneficial part of the service and it was really well received. They also got advice and information, as did the person, during those pre and post assessments when they met with myself remotely or one of my colleagues. So I decided to do an audit of the service, given the fact that it was the first post-diagnostic service that we had established in Our Lady's Hospice, and really to identify, were we meeting the standards that are set out by kind of international standards, the NICE guidance, as I mentioned already, and then MSNAP that reinforces this, that group CST should be offered and that it should be aimed at enhancing both cognitive and social functioning. So they were the two standards that I went to audit the service on, and also really to justify the need of the service and to enhance the future service delivery and improve patient care. So they were the main aims of the audit. So in terms of the audit findings, just to give you a breakdown of people who were actually referred to the service, we had 74 people referred over the course of the year. So for a new service, I think that was really successful. I did a telephone screen with those that were referred, and of the telephone screens, I did 28 people cancelled or were unsuitable at that point for various different reasons, like admissions into long-term care facilities, people who were unwell, those who maybe had conflicting activities on a Friday, or people who had just decided that actually the CST maybe wasn't the right fit for them. 34 people were offered a pre-assessment, and of those 34 people, 24 were accepted to the programme. So we had 3 10-week programmes facilitated over the course of the year and 20 participants. So I suppose looking at the audit standards that we were auditing against, we did, I suppose, comply with those standards because it was the first time that CST was offered within our own service, and it was, from our knowledge, the only CST service in our catchment area at the time. Another really significant finding, I think, is that on average across the 3 programmes, 9 out of 10 of the sessions were attended by the participants. So we were really glad to see people that were coming back week on week. In terms of whether or not it was aimed at improving kind of cognitive and social functioning, we did look at our outcome measures that we used as standard, and what we noticed was that the mean cognitive function across the groups measured higher at the end of the CST for participants. So that was also a really significant finding to suggest that actually cognition was improving, along with, I suppose, trends towards improved mood and communication skills. And that was really reflected in the subjective feedback forms. And that was really, I suppose, observed from ourselves facilitating the groups who noticed, I suppose, that people would really develop in terms of their ability to participate in a group, their language skills, in addition to their cognitive functioning as well, such as attention and orientation particularly. So just to give you a breakdown of those more subjective feedback that came back. So we asked participants and carers to rate their mood following the group. So 80% felt that their mood had improved from the CST group. And in addition to that, when we asked if the group helped communication and interaction skills, 76% of people felt that yes, it did improve their kind of social skills in that way, and 24% felt that it might have as well. So again, really positive feedback in terms of those social skills. In general, most people did say that they would recommend the programme to others, and there is a number of different reasons why people felt that it was important for people to participate in CST when they were given a diagnosis of dementia. So I'm just going to read some quotes here from participants and their carers. So one participant here said that it felt fun. It was fun and felt good and comfortable with everyone. I was not rushed and I gained confidence. Another carer gave feedback here saying, this programme makes people like my mother feel special and important. Therefore, I would be more inclined to promote the great work the staff do in managing and caring for people like her. And just one last one here, that yes, because it benefited us as a family and improved the mood. So really significant findings, and really important there to hear the voices of the people attending the groups. The aspects that people found most beneficial, and I mentioned this earlier on, and it was interesting to see that this came out actually in the feedback forums, is that people did feel that it was a very safe environment. And I think that that comes with the ethos of CST, that because it is opinions based and it should be, you know, very much based on the person's strengths and supporting them to engage within the group however possible. People felt they were given enough time so they weren't rushed, and that there was humour and fun. And I think that that's also really important when delivering CST, in that it should be fun. People should have an enjoyable experience attending the activities while they're stimulating their cognitive function and social function as well. People really enjoyed the interaction with other people. We were really lucky at the time. We had a cozy sitting room that really supported that kind of natural engagement as well. So I think that was another really good benefit from it. So just I'll read one last quote here. Just, there was a sense of comfort, good humour, and a chance to mix with people and socialise. Loved singing, and I really looked forward to coming here every week. So I'm just going to finish up just to give you a sense of where we're at now and our plans really moving forward with the service. So unfortunately, back in March, because of COVID-19, and I know a lot of people are talking about this throughout their presentations over the 2 days, and how we've all had to think creatively and really change our services to try and meet the needs of the people living with dementia in our communities, because there is a massive, massive need there. So we've been working hard in Our Lady's Hospice to remodel the service, and I suppose from a CST perspective, what I have shifted to now is that I meet with the person and the carer, and I would provide a training session with the carer in terms of delivering CST or individualized CST at home with the person. So what that involves really is that there's a number of different session plans or activities that can help kind of mental stimulation within the home environment. And I suppose it's been interesting to see that there are a lot of carers, particularly, you know, that are living with the person with dementia, that really are really encouraged by the different resources that are out there to support activity and to support mental stimulation at home, and are really grateful of the training and support and how to go about that. So that's the individualized CST that I now offer to the person with dementia and their carers. I've also linked in with researchers, Amy Spector and her team over in the University College London, about running virtual CST groups, and I'm hoping to start that in the coming months for people with dementia as well, which will be interesting to see how people respond to that. And it is a new way of doing it, but there have been, I suppose, quite successful trials over in New Zealand in facilitating CST virtually. So we're looking forward to getting that started in Our Lady's Hospice as well. Just lastly, I guess, really the post-diagnostic service, we've had a chance as a team to look at it and to develop it even further. So we now have a candidate AMP, and working with the AMP Chris and with our geriatrician Dr. Purcell, we've remodeled the service so that the person gets a comprehensive assessment from the AMP when they come in, and then there's access to myself from occupational therapy, Dr. Purcell as the geriatrician, and then Dr. Green from the psychiatry of later life over in St. James's Hospital. So it is, I suppose, it's expanded from just the CST to a much broader service in which we can offer to our patients now. So in general, I suppose we have had to remodel things and relook at things, but we're hoping moving forward that will actually be of more benefit to the person. So just to say a massive thank you to the organisers of the Dementia Conference and to yourselves as participants. If anyone has any questions, just pop them in the chat box, or more than happy to answer any questions through email as well. Thank you very much.
Thank you, Claire. That was very interesting. So yeah, so if you put any questions in the chat, then we can get to those in a little bit. So now I'd like to introduce to you Caroline Kilty. She's a lecturer at University College of Cork, and she's going to be talking to you about pathways for people living with younger onset dementia.
Thanks very much, Kim. So my name is Caroline Kilty, and I'm teaching in the School of Nursing and Midwifery in UCC. So I'm here to discuss a study that was done as part of a wider project on young onset dementia, looking at diagnostic pathways and processes. So the project was commissioned by the National Dementia Office, and the final report was launched about a month ago. It was written by my colleagues Siobhan Fox, Professor Suzanne Cahill, Rachel McGowan, and myself, and we had significant contributions from our project collaborators in the team as well. I have them listed here. So many thanks to my colleagues on the overall project. So looking at what I'm going to bring you through today are just the findings of a literature that we did as one part of the overall project. So Professor Suzanne Cahill directed and led on this element of the report. So we conducted a literature review on diagnostic processes, and we also conducted a literature review on the post-diagnostic pathways. So you can see on the bottom, we also held interviews with healthcare professionals and in-depth interviews with people with young onset dementia and their families. So today I'm just going to discuss the element relating to the diagnostic processes literature review. So we knew historically that, and even recent years, the services for young onset dementia were identified as suboptimal, and there was real challenges in obtaining a diagnosis that was specific and that was timely and that was confirmed. So we first of all aim to review some of these diagnostic processes as they were internationally, and have a look at some of the Irish policy context as well. So the aim of the report then is to support decision making on dementia diagnostic and post-diagnostic processes in Ireland, and hopefully to inform the ongoing development of a model of care for people with young onset dementia. So the research questions guiding the literature review were to explore what models are available nationally and globally for the diagnosis of young onset dementia and the evidence to support these, to look at the differences in diagnostic processes and pathways between young onset dementia and late onset dementia. So we conducted a structured literature review. We looked at some of the key databases in the area and explored some of the grey literature repositories. Our review or strategy was reviewed by our project group. We used the typical data management software, and we used a narrative synthesis approach to synthesize our findings that allows for kind of a lot of these different types of studies that we came across when we were looking at younger onset dementia. So lots of different types of designs, methodologies, different areas of exploration that we retrieved. So we found we identified 189 scientific works. We included them for full review. So as I said, there was different types of study designs, different methodologies, and there was papers on different types of dementia subtypes within the young onset dementia profile. So there was different types of terminologies described in the literature, different ways of referring to young onset dementia, and different age cutoffs, depending on different countries. So that impacted on the literature that we retrieved. So generally speaking, the term young onset dementia is widely used, and the age cutoff is generally in and around age 65. So prevalence, there is very little in terms of definite prevalence studies, and the same goes for Ireland, unfortunately. So there are some variable results. There's no Irish-based epidemiological study, and the exact numbers of young onset dementia varies depending on different ways of approaching the final number. So we can see there's variations between around 3,000 to 4,000 people with dementia as of 2019. So then looking at our findings, just relating to causes of young onset dementia. So there was more unusual dementias within the literature, a greater likelihood of genetic or metabolic diseases. People were more likely to have a rare form of dementia that affected behavior, mood, and functioning in the early stages. So within the subtypes, Alzheimer's was amongst the most common subtype. Frontotemporal dementia and alcohol-related dementia were leading amongst those within that number. So that's different to the typical age dementia profile, where dementia with Lewy bodies and vascular dementia feature. So this featured in a lesser extent in people with young onset dementia. There was a larger number of rare dementias like Huntington's disease related dementia, CJD, and Korsakoff's disease. So there is a wide differential diagnosis and a wide range of subtypes of young onset dementia. So this all adds to the profile of it being quite difficult and challenging for diagnosis to be reached in a way that's timely for the person and for their family. So the distribution of diagnosis differs significantly between late or typical onset dementia. So people with dementia, with young onset dementia, in the literature were more likely to have these atypical presentations where memory was not necessarily the heralding feature, memory issues weren't the most prominent issue. So this means that some of the earlier, rarer signs that people were living with for some years were not well recognized. People received misdiagnoses, or their dementia or their issues were attributed to different types of causes. So some studies highlighted the overlap between neurodegenerative diseases and psychiatric issues, which meant that people with dementia had these types of diagnoses first, these mental health diagnoses. So their changes in mood and cognition were attributed to issues such as depression or anxiety. In some studies, it was work-related stresses or perimenopause. So looking at findings as it relates to international literature first. So just to take a kind of a snapshot overview, some of the major differences that we find when we were comparing young onset dementia with late onset dementia. There were significant differences relating to the subtypes of dementia, the time to diagnosis, which I'll touch on in a while, the presence of other illnesses at the same time, and the presence of behavioural and psychological symptoms. Obviously, stage in the life course was very different for people who were under the age of 65, and then time to long-term care in some studies was expedited in younger persons. They were a shorter pathway to long-term care. And of course, the impact on family members as well is significant. So there was a consensus within the literature about the average time to diagnosis being considerably longer for people under the age of 65, in some cases twice as long. And I'll pull out some examples of the differences in terms of actual time. So there was variation in the delivery of diagnostic services. And what was interesting was even those countries that had dementia-specific services and national dementia strategies and frameworks already in place. So those countries like Norway, Sweden, and the US, even those countries did not necessarily have coordinated policies in place to steer young onset dementia specific services. So some countries applied a strict age cutoff when it came to accessing dementia services, such as accessing geriatricians, old age psychiatrists, and memory clinics. And then in some countries, such as Canada, there was no differentiation made in age. So people were able to access related services like memory clinics and geriatricians, regardless of their age. So I've just pulled out some examples of diagnostic care pathways in the international literature. When there was examples of different services being involved and non-dedicated young onset dementia services, there was reports of impacts on quality and consistency of care for people with young onset dementia. So care pathways were described as chaotic, and the unique needs that people were living with, they didn't necessarily receive the expertise that they needed for this, that was lacking in the literature. So there is one example from the many I've pulled out from the review of Draper, who conducted a study with 88 participants. Within this study, the mean number of clinicians that the person saw to retrieve or to obtain a diagnosis was 3, and in some cases that was as many as 6. The time between symptom onset to first consultation was 2.3 years, and to the final diagnosis was 4.7 years, so nearly 5 years before the specific type of dementia was confirmed, which, you know, we can tell is a really a long time for people to be waiting for confirmation. GPs were the most frequently seen clinician, and they were often mostly the first port of call. We'll touch on that. I'll touch on that again in a bit about this, you know, the prominent role of GPs in the care pathway for people with young onset dementia. So the first specialist was usually, in this case, a neurologist, followed up by memory clinics were the most likely to offer the final diagnosis, as well as neurologists and geriatricians. Some of the factors that was associated in this case with delays were presence of, obviously, the younger age being a factor that led to delays, and the presence of depression or mild cognitive impairment, and if the person was living with frontotemporal dementia, this was also associated with the delay. And half of the participants here received a different diagnosis before the dementia was diagnosed. Examples of the types of diagnosis people received were alcohol use disorder, depression, and other unrelated medical, neurological, and psychiatric diagnoses. So I've just pulled out some findings from the literature relating to optimal care pathways, so what ideal pathways might look like. So in the UK, there was the Young Dementia UK report. They highlighted an optimum care pathway with gold standards, and it's similar to the NICE guidelines from 2018. They've highlighted the importance of clear pathways to assessment, timely diagnosis, and consideration about the importance of the disclosure of dementia. They highlighted some key elements that should be present for diagnostic assessment, including, for example, a cognitive assessment with a neuropsychologist, and also access to specific diagnostic testing if required, like CSF analysis. So disclosure, that time whereby a person is met with the MDT or with the memory clinic and the diagnosis is named. There was discussion in the literature around pre-assessment counselling being performed to ascertain what the person would like to know about their diagnosis, who they'd like present with them, who they'd like informed when the diagnosis is confirmed, a GP, or who they'd like involved in their care ongoing, and that this will be held in a confidential setting. There's also a point about a named professional being responsible for service planning and clinical input, so a designated clinical lead for young onset dementia. So just look at the Irish policy context. So the National Dementia Strategy has highlighted some of the real unique issues experienced by people living with young onset dementia, and here too the role of the GP in diagnosing is highlighted, but emphasis is placed on specialist input for specific subtyping. The National Dementia Strategy highlights the role that neurologists, geriatricians, older psychiatrists, and memory clinics, they all have a role to play in diagnosis and subtyping. That is not necessarily the responsibility of any one particular specialty. So best practice should emphasise flexibility and fluidity between services. That was based on a recent Irish review of diagnostic services for dementia generally, with access to regional centres for any difficult to diagnose cases or atypical cases. Pathways should allow for a range of different assessment diagnostic testing to meet the need of complexity, that people should have that, you should have access to different types of assessment methods depending on the need. with regards to, imaging, specialist time travel. And of course, an acknowledgement that the local context is just as important while the evidence is evolving. So my last two slides are just relating to what we've pulled out here from the literature, relating to the time prior to diagnosis, that there needs to be a consensus on. There is a consensus on the importance of timeliness, social, emotional, psychological impact, and the benefits, potential benefits of obtaining a timely diagnosis. And here at the beginning, there is the importance of the GP, preferably being a skilled GP who's knowledgeable in young onset dementia. At diagnosis, referral is made and a pre-diagnostic review is undertaken, ascertaining what the person would like to know and how, and disclosure. A real consideration is given to this time of disclosure, and it's offered by a skilled clinician and relevant members of the MDT. And after diagnosis, there would be a real cognizance taken of the complex factors such as employment, dependence the person might have, and additional responsibilities. If the diagnosis is made in a national centre or regional centre, there has to be a clear exit plan back to the person's locality, and any post-diagnostic intervention should be started in a manner that's timely for the person when they're ready. So my final slide, just to remind us that there's no specific practice guidelines in place as of yet. Timely diagnosis remains amongst the most pressing issue, and the GP and the use of MDTs is critical to get this timely diagnosis started. Some of the key elements from the literature of a diagnostic service provision are clear pathways to assessment, diagnosis and consideration of disclosure, and referral to specialist and generalist post-diagnostic services. And there is this need to ensure services are integrated, whether they're primary, secondary or tertiary. And looking more generally at young onset dementia service design, the importance of an individualized model and access, equitable access to diagnostic services, ongoing symptom management, that this all doesn't end after the time of diagnosis, that the person is started on an integrated care pathway, and of course a need to highlight or to develop these best practice guidelines in diagnosis in young onset dementia. So thank you. This is our report. It's available from the National Dementia Office and the HSE Understand Together website. Thank you.
Thank you very much, Caroline. That was very interesting. So I'm just going to bring the rest of the panel back. Hello, everybody.
Hi.
That was a very interesting bunch of presentations. So if anybody wants to ask any questions of the panel, if you guys can put it in the chat or the question and answer function. So Karen, a question came in for you. You work closely with PHNs. Do PHNs refer to you if they have concerns if the client is known to you? Do family members contact you or the PHNs?
So I usually send referrals to the PHNs, but at this stage, as we're 2 years into the program, we would, I've maintained relationships with the patients and with the families. So the public health nurses and myself, we all sort of know each other. So where we have families and people with dementia in common, if there's any changes or any struggles, then they will link the people back into me. So it's a kind of a two-way pathway, if that makes sense. And then any issues that are identified, they will let me know, and we might be able to make an earlier referral, or even it's just a case of maybe a conversation with me, something like that. So it is a bit of a two-way pathway, as long as they're already known to my services. If they're not, then they have to go through the GP first to be linked in. I hope that makes sense.
Yeah, exactly. So if that wasn't clear, then if you can just let us know in the question and answer area. So then, Don, I had a question for you about the cognitive daisy. What is the largest challenge that you found to implementing this?
The largest challenge? Yeah, I suppose it's trying to, well, in care homes, a lot of carers are under a lot of pressure. And so I think it's been, in some care homes, it's been basically that kind of commitment to using it regularly. In some care homes where they've bought in, particularly the management and senior care staff, it seems to sort of work really well. But it's that buying in, really, I think, from the carers.
Mm-hmm.
That's the biggest challenge.
And once they're on board, then it's easier.
Yeah. In some care homes, it's kind of been quite spontaneous, where it becomes a part of the language they use. And even though the trials ended, they've wanted to keep the data in the materials, because it's changed how the terminology they use to describe different kind of problems in dementia. But then others where there may be language areas, they found some of the training might have been a bit more difficult, those kind of things. They've been particularly stretched to do the training. Those are the kind of barriers, I think.
Mm. Very good, very interesting. And then Claire and Caroline, I was just wondering if you could give us some insights into how COVID is actually making it things more challenging for you to change things in the new way of doing things.
Yeah, well, definitely for ourselves over in the hospice, we've really had to restructure and remodel the service, just because our model was based on a group, and at the moment, unfortunately, we don't have a big enough space to facilitate that, and just with current restrictions, it wouldn't be advised anyway. So it has definitely been a challenge, and we've had to look very creatively at how we can do things. But I think what was helpful is that from the start of COVID, we started to brainstorm and work together as a team, so that now we're in a much better position. And I could hear that from Karen as well. Just, it was actually nearly like 2 phases. It was the initial phase of that everything had to stop, and really trying to just see, how you could do telehealth or phone people and kind of link in. And then I suppose this phase now is, the restructuring and remodeling, so that we can still offer a service to the people who most need it, but just doing it in a different way. Because as Karen mentioned, they haven't had any DNAs. That just shows you it's similar with ourselves. People really need the service, and are still very much wanting to come in to meet face to face where possible and where safe to do so as well.
Very good. Thank you, Claire. And then Caroline, I'm assuming that diagnosis is being impacted because of COVID. Are there other things that are also making things more difficult?
Thanks. And I guess, my point was just maybe that there are lots of challenges now that we're facing in the area of long-term care. And I guess it's up to people like us and the authors of the report to ensure that we keep the agenda now for people who are living with young onset dementia, that we make sure that we get our research out there and that it's widely disseminated, and that we make sure that we keep that message prominent, particularly during a time where diagnostic services or post-diagnostic services might be overstretched or not necessarily highlighted.
Yeah, no, that's a very good point. So there's no more questions coming in. I'm just going to launch a poll now for the attendees to give us some feedback. I want to thank all of the panelists. That was very interesting. I very much enjoyed that. As I mentioned before, this session has been recorded, and so when it's up online, we'll let everybody know. There's one more session this afternoon, so we hope that everybody will attend that one. And if you guys want to go on Twitter and make any comments, if you could use the hashtag @DementiaConf2020, and then also tag Engaging Dementia, we'd really appreciate it. Oh, let's see, there's one more question coming before we go. So thanks, Caroline. There are very little services for people with dementia under 65. Can this change?
Thanks. That's a really good point. I would really hope now that this report will be directly informing the development of a specific model of care for people who are living with young onset dementia. So the initial plan was that this would be these findings, the overall findings would feed directly into the development of this model. So we've just got to be hopefully positive and keep our eye on the National Dementia Office to see any developments from there. It couldn't be more invaluable. I think it's so vital.
No, agreed. Oh, and another question. Yeah, so just a comment. Yes, that would be great. So there were some additional compliments in the chat. So very interesting session. That was very much enjoyed. So thank you guys. Thanks again. And I will see you hopefully in the next session. Thanks so much.
Thank you very much, Kim.
Bye.
Bye.
Bye-bye.